session deals with the evaluation, treatment, and follow-up of patients with non-alcoholic fatty liver disease, or NAFLD. Upon completion of this activity, you should be able to choose appropriate diagnostic tests, recognize non-alcoholic steatohepatitis or NASH, the inflammatory variant of NAFLD, identify clinical situations which warrant further diagnostics, and recommend pharmacologic and non-pharmacologic treatment options to your patients. Let's start with a common clinical scenario. A man consults you in clinic because of an elevated alanine aminotransferase, or ALT, found on pre-employment medical screening. He is asymptomatic. He drinks 1 can of beer daily after work. He has no history of diabetes. His body mass index is 30. The rest of the physical exam is normal. Which test should be requested next? Is it A, transient elastography, B, abdominal ultrasound, C, triphasic CT scan, or D, abdominal MRI? Let's move on to the next question. Steatosis is seen on ultrasound. After exclusion of other hepatic diseases, a diagnosis of NAFLD is made. Which of the following therapeutic options should be tried first? A, lifestyle modification, B, vitamin E 800 international units per day, C, ursodeoxycholic acid 10 milligrams per kilogram per day, or D, early referral for bariatric surgery. We will discuss the answers at the end of the session. NAFLD is hepatic steatosis, or fat in the liver, seen on either imaging or histology. Imaging may be with ultrasound, CT scan, or MRI. Secondary causes of hepatic fat accumulation must be excluded by history, physical exam, and diagnostic tests. The extent to which tests will be ordered will depend on each patient's clinical picture. The gold standard for diagnosing NAFLD is liver biopsy. Liver biopsy reliably differentiates simple non-alcoholic fatty liver from non-alcoholic steatohepatitis. The diagnosis of NASH requires all 3 elements shown in this slide: steatosis, ballooning degeneration of hepatocytes, and lobular inflammation. The absence of any one of these features leads to a diagnosis of non-alcoholic fatty liver, or NAFLD, without NASH. Evaluation of potential NAFLD patients proceeds in a stepwise fashion, beginning with exclusion of significant alcohol intake. Significant alcohol intake is more than 20 grams per day for women and more than 30 grams per day for men. A thorough history to assess for diabetes, hypertension, and cardiovascular disease must be taken, as these diseases are associated with NAFLD. A history of viral hepatitis and intake of steatosis-causing medications are also significant. Physical exam should include body mass index and waist circumference. Laboratory tests should include ALT, AST, fasting blood glucose, and hemoglobin A1C. An oral glucose tolerance test and the fasting insulin for computation of HOMA-IR, or homeostatic model assessment of insulin resistance, may be requested in selected patients. A fasting lipid panel should be done. Viral hepatitis serologies are necessary. Non-invasive tests are used to identify risk of NAFLD, identify those with worse prognosis, monitor disease progression, and predict response to treatment. Ultrasound is the first-line diagnostic procedure because it is widely available and relatively inexpensive. In obese patients, an MRI may be more reliable should ultrasound be technically difficult. Serum biomarkers such as steatotest and fibrotest reliably predict the presence of, but not the severity of, steatosis. When biopsy is not feasible, biomarkers combined with transient elastography is a reasonable option. In patients in our clinics who have metabolic risk factors, liver enzymes should be checked and an ultrasound done. If liver enzymes are normal and steatosis is absent, liver enzymes and an ultrasound may be repeated in 3 to 5 years. If liver enzymes are normal, but steatosis is present on ultrasound, serum fibrosis biomarkers may be requested. If biomarkers do not suggest significant steatosis, the patient is considered low risk for NASH, and tests may be repeated after 2 years. If biomarkers suggest significant steatosis, then specialist referral should follow. If liver enzymes are abnormal and steatosis is present, specialist referral is also recommended. Treatment begins with lifestyle modification. Lifestyle correction is mandatory in all patients. A goal for weight loss of at least 7 to 10% of current body weight is advised. This can be accomplished with individualized recommendations on calorie restriction, with a daily 500 to 1,000 calorie deficit until weight goal is achieved. Macronutrient composition adjustments should be made in favor of moderate healthy fat intake, high fiber complex carbohydrates, and higher protein intake. Alcohol intake should not exceed risk threshold. Moderate coffee drinking is not detrimental to NAFLD patients. A minimum of 150 minutes per week of aerobic exercise, in addition to resistance training, should be encouraged. Pharmacologic treatment should be reserved for patients with evidence of progressive NASH or early NASH with risk factors for progression. Risk factors include age greater than 50, diabetes, metabolic syndrome, or active NASH on biopsy. No drug is currently approved specifically for NASH. Any drug treatment would be off-label. There is no recommendation for metformin due to insufficient evidence. Pioglitazone, a PPAR-gamma agonist with insulin-sensitizing effects, may be used in patients with type 2 diabetes. Pioglitazone has been shown to produce histological improvement and normalization of ALT in non-diabetic patients. However, in the absence of diabetes, the side effect profile of pioglitazone becomes a concern. Vitamin E at a dose of 800 international units per day was shown to induce resolution of NASH in a third of patients. However, due to safety concerns, including effect on mortality, hemorrhagic stroke, and prostate cancer in males older than 50, vitamin E should be reserved for non-cirrhotic, non-diabetic NASH patients. Trials with ursodeoxycholic acid showed biochemical improvement without histological improvement. Obeticholic acid may lead to histologic improvement in non-cirrhotic NASH patients, but these data are preliminary. Statins have shown neither benefit nor harm with NAFLD. Other agents such as polyunsaturated fatty acids, pentoxifylline, orlistat, and ezetimibe are under study. In patients in whom diet and exercise fail, bariatric surgery is an option. Bariatric surgery may halt progression to cirrhosis and can lead to histological improvement. Should NASH progress to end-stage liver disease, liver transplantation may be performed. 3 and 5 year survival rates are similar to other indications for liver transplantation. So, to answer a clinical question posed earlier, abdominal ultrasound is the diagnostic of choice for the obese, asymptomatic man with elevated ALT. Abdominal ultrasound is relatively easy and inexpensive and should be requested ahead of other tests that pose more risk to the patient or entail significantly larger costs. The answer for initial therapeutic option is, as always, lifestyle modification. Lifestyle modification, more than pharmacologic therapy, will have a greater impact on outcomes. Bariatric surgery should be considered if both non-pharmacologic and pharmacologic interventions fail. This brings our session to an end. I hope you are now able to select basic diagnostics for a patient with risk factors for NAFLD, to more closely monitor a patient with NASH, and to start both non-pharmacologic and pharmacologic interventions. Thank you.